In this final lesson of Module 3, we bring it all together. You've mastered the views. This lesson is about pattern recognition when the stakes are highest. We will focus on 3 critical red flag patterns, 3 killers you can spot from the apex that will change patient care in seconds. This isn't just image acquisition, this is clinical power. Now, let us see how they save lives. From tamponade to significant valvular dysfunction, here is what you must never miss when scanning from the apex. A 55-year-old patient presents hypotensive and tachycardic with muffled heart sounds. Your patient is in shock. You place the probe at the apex and see this. The black echo-free space is a large pericardial effusion encircling the heart. But the true red flag isn't the fluid itself. While large effusion can impact the loading conditions of the heart, the true red flag is what you see here. Look closely at the right ventricle. In diastole, the free wall collapses inward. This diastolic collapse of the right ventricle is the definitive sign of cardiac tamponade. Remember, a good ECG tracing is always your friend, so you can always time the finding with the ECG. You can see the early diastolic collapse clearly timed with the ECG here. You are witnessing obstructive shock in real time. Now, there are more subtle signs of tamponade that we cover in the next module, and more that we cover in our advanced courses, but for foundational emergency echo, this is the most important sign you are expected to pick up and not to miss. The apical 4-chamber is a very reliable view for spotting chamber collapse. Right atrial collapse is an early sign, but seeing the RV cave in during diastole is the hallmark of a true emergency. In our next case, we are looking at an 82-year-old patient who arrives in the emergency department in severe respiratory distress and hypotension. On the apical view, instead of seeing a strong LV squeeze, we observe severe LV dysfunction. There is clear akinesis at the apical segments, which denote involvement of the LAD territory with previous LAD infarction. There is significant hypokinesis in the lateral wall as well, suggesting involvement of the LCX territory or a diagonal branch. The inferior septum looks relatively preserved. That means the RCA territory is likely intact, but the overall left ventricular function is markedly reduced. This is a key red flag of severe LV dysfunction and likely cardiogenic shock given the presentation. Additionally, you notice a hypodense area near the akinetic segments in the apex, raising the suspicion of an apical thrombus. While a full comprehensive echo would help differentiate artifact from a true thrombus, your role here is to flag this as a serious concern. Also note in this clip that the interatrial septum markedly shifted to the right, which is in keeping with a high LA pressures and elevated LV filling pressures. Always correlate these findings clinically, but know that you've just identified a crucial red flag using the apical window alone. In this final scenario, we have a 40-year-old patient with a history of intravenous drug use who's been feeling unwell for weeks and now presents to the emergency department with severe breathlessness. During your bedside assessment, you noticed that there is a loud diastolic murmur. On echocardiography, you notice from the apical 4-chamber view that both ventricles have normal contractility with normal longitudinal and radial function. However, looking at the apical 5-chamber view, you notice that there is a mass attached to the aortic valve oscillating and prolapsing into the LVOT during diastole, with color Doppler on top of that, you notice that there is a broad jet of severe aortic regurgitation confirms your suspicion of infective endocarditis causing valve destruction. In fact, this was confirmed in the parasternal long axis focused view on the aortic valve that confirmed a flailing non-coronary cusp of the aortic valve with an attached vegetation causing destruction of the aortic valve leaflet, resulting in severe aortic regurgitation, which we will call at the foundational level significant aortic regurgitation, occupying more than 65% of the LVOT width visually, which is in keeping with significant aortic regurgitation, which we would quantify in a comprehensive study as severe aortic regurgitation indeed. This is another red flag that was picked and identified through the apical window. As we wrap up this lesson, we have seen how the apical views can reveal critical emergencies, from tamponade to severe LV dysfunction to aortic regurgitation in endocarditis. This is just a taste of what mastering the apical window can offer. We are still in the foundational phase of the standard windows and the standard views, and more in-depth emergency lessons are ahead. You've now completed the entire apical window module. You've now mastered the two primary windows for echo. But what happens during cardiac arrest and you have only 10 seconds to look at the heart and get your answer? Or when your patient has severe lung disease or on a ventilator and you can't get a clear parasternal or apical view? In our next module, we master the essential problem-solving window, the subcostal window and the subcostal views. I will see you there.